Okay, guys. So today we will be starting from embryology and anatomy of cardiovascular system, right? So, guys, first of all, some things regarding the cardiovascular system. Can all of you see my screen? Okay.
Yeah, but
Right.
it's blurry.
Is it clear now?
Yes.
Okay. Okay, guys. So, first of all, some things regarding cardiovascular system, right? So, the first, number one thing is that a lot of people, a lot of students find cardiovascular system very hard regarding step one, step two, and step three. But believe me, it's the most easiest system that you will get, right? So, if you to prepare it good, if you get good concepts of it, it would help you a lot. Right. So, cardiovascular system is really important. With that, regarding that, the anatomy, embryology, and physiology is really important, especially the physiology. If you get a good hand of the physiology of the cardiovascular system, everything is gonna get very easy for you. But if you do not get a good hand, things will get very hard for you, right? So without further ado, let's start from the morphology, right? So the embryology, right? So the first most important thing that you guys want to remember is that the heart is the first organ in the body that develops, right? So it's the first functional organ that will develop. And the second most important thing is that it starts developing at fourth week of the development. So why is this thing important? This thing is important because the USMLEs can ask this thing in a thousands of ways, right? So they could give you a question that, for example, 25-year-old female comes to you and she is pregnant, right? So you perform a beta HCG test and the test is positive, and after that, you do an ultrasound of the baby, right? And you see something at the fourth week of development. So you see something, or you see an organ that is present at the fourth week. So the female is fourth week, is at the fourth week of pregnancy, and she is having something on the ultrasound. And then they could ask you, what is this structure, right? So that structure obviously would be the heart. So right, so that is the number one way that they could ask you this question, right? Now, the second important thing is that, let me make another page here so things become a little easier, right? So now the second thing that comes here is that at fourth week of development, so if we see the heart will be like this. So the heart will be a straight tube like this. But then at the fourth week of development, a thing occurs which is known as the cardiac looping. So what is the cardiac looping? The cardiac looping means the heart will loop around like this, and we will get a proper structure of the heart at fourth week of development, right? So this looping will occur throughout the body, and this process will be known as the polarity of the body, the formation of polarity of the body, right? So what this thing will do is that there will be a left and right in the body, right? Some things will move to the left and some things will move to the right. Right. So why am I stressing on this? So guys, remember one thing regarding the USMLEs. The most important thing is that everything that you see in step one and step two, especially the basic knowledge, all of that basic knowledge has a background. Like, why are they asking you that question, right? So why am I teaching you this thing? Why is this polarity important? So every single thing happens for some specific reason, right? So for every single thing that is important, or every basic concept that they are testing you, it's because there is a clinical condition behind it. So doesn't remember everything in that way, right? So in cardiac looping, the main thing that will happen is that the heart would loop and whole of the body would develop a left to right formation, right? Now there is a structural protein that is involved in doing this, and that protein is known as the dynein, right? So we have a protein which is known as the dynein protein, right? So the dynein protein is very important in forming the left to right symmetry of the body, right? So it forms the asymmetry of the body, that some things will be on the right. So if I say the aorta is on the left side of the body, the inferior vena cava is on the right side. Liver is on the right. So let's make this. So liver will be on the right side, whereas stomach will be on the left side, right? So how does this thing happen? Now, the USMLE is a very interesting in this thing that how this thing happens. So this thing happens due to a protein which is known as the dynein protein, right? So when this dynein protein is absent, this left to right asymmetry, this left to right thing will disappear, and the things on the right will go on to the left side of the body, and the things on the left will go to the right side of the body, right? So this condition is known as a syndrome, which is known as the Kartagener syndrome, right? So what is Kartagener syndrome? So that is the most important thing that we are going to study today. That would be Kartagener syndrome. So Kartagener syndrome means that there is a problem in a dynein protein. So whenever I am teaching you something regarding me, you need to make some certain things clear. So the first thing is that we should be clear on the pathophysiology of every single disease that we are going to study, right? And whenever you are studying in step one, always keep these things in mind. So first thing is that the pathophysiology should be very, very much clear in your mind. The second thing is that the symptoms of the disease, how does that disease present? What are the signs of that disease? What is the diagnostic steps? What are the treatment steps? What are the complications, right? So keep all of these things clear and steps will get very easy for you. So simply the pathophysiology is very simple, that there is a problem in the dynein, and as a result of that there won't be any left to right formation of the body, right? So what will happen as a result is that the heart will be on the right side of the body as compared to the left side of the body, right? And again, there would be some other things as well. So dynein is in what motility, right? That is the another function of dynein. So dynein is involved in the motility of the body, right? So where do we need this motility? Wherever we need this motility, that thing will be affected, right? So for example, in the nose, we need this motility to clear the secretions. So if the secretions aren't clear from the nose because the dynein is having some problem, so those secretions will get stuck in the nose, and as a result, we would have nasal polyps, would have nasal infections. Now, things will get stuck in your ear and they won't go out, so you would get recurrent otitis media, right? Things will get stuck in your lungs and you would get lung infections, right? Now again, the heart will be on the other side of the body. You cannot transfer your sperm. There won't be any sperm transfer. There won't be any egg transfer. Why? Because dynein is having a problem. So whenever these problems will be present, there will be infertility, right? So now they could give you a question that, um, so now let me tell you how USMLEs make easy things very hard for you. They could give you a question that a female comes to you or that a male comes to you with a problem of infertility. So now they will give you the main thing, the main problem here will be that the person will be having infertility. And then they would say that this person is also having recurrent infections in the past as well, right? So now you would think that this person is having some kind of immunological problem, right? But the important most thing is that these were the symptoms. There would be one sign. The question would say that when you auscultate the heart of the person, you come to know that the sound that is the heart sounds are present on the right side of the body. And at that point, you want to know, you want to make sure that the diagnosis is Kartagener syndrome. And then they would ask you, what would be the pathophysiology of this disease? What is the pathophysiology of this disease? So the pathophysiology would be that there would be, so now they could, now, so the thing is that now they could morph the pathophysiology into different ways, so as to make it clear for you, right? So they could say that problem of morphogenesis, a problem of heart looping, a problem of establishing left to right polarity, or they could say a problem of motility, right? So they could say that any of these things could be present. But once you have a good angle of the pathophysiology, you know that there is a protein which is known as dynein, and dynein is involved in establishing the right to left polarity, and that right to left polarity would be causing the problems, and at the same time there would be motility problems as well. You could get person, right? But these are the signs and symptoms that you should keep in your mind, and that would help you detect these problems, right? Now, let's move in. Let's move into. of the chambers. Right? So the number one thing is that we have so now we have a thing which is known as a septum primer. So first of all, if this was a heart tube, the heart tube will move to something like this. Right? So this becomes our right side of the heart, and this becomes the left side of the heart. Now, the problem is that both of these sides are connected with one another. So now, if we look at the frogs and other animals, in those animals, these things are not separated from one another. There is intermixing of the blood. Here we want the intermixing. So how do we make that intermixing? So in order to make that septum, the difference between those members, first of all, a thing to go which is known as a septum primer. So an endocardial cushion comes here. I would go into the detail about endocardial cushion later, but you want to see that an endocardial cushion will come and septum primer will come from here, and it would divide the heart into the right and left sides. But the important thing here is that there would be a very small gap, which would be known as the ostium primum. Right? So this would be the ostium primum as we can see here. Why is this important? I will let you know later. So after that, in this septum, which is a septum primum, an ostium secundum will be formed. So ostium means an opening, and an opening will form in the ostium primum.
Sorry to interrupt, Dr. Moaz. Your voice is breaking. So can you just please fix that?
Okay, just give me a minute.
As you're fixing your mic, so let me just have a little bit discussion with students, right? So as Dr. Moaz explained really well about Kartagener syndrome and dextrocardia, so one of the students was asking a question that how do the flagella or the sperm lose its mortality, right? So the answer for that is that dynein is a protein, right? And it's responsible for movement of both of your cilia and flagella, right? And as Dr. Moaz explained that whenever we have problems with these ciliary structures, there is going to be infection, whether it's in ear, whether it's in lungs. And the idea for that is whenever we have problems with this movement, there is going to be stasis, right? Stasis, like for example, we know in the lungs, cilia helps all of the particulate substances to move upward into the pharynx. Either you can just swallow it or either you can just, like spit it out, right? But as these cilia get non-functioning, we are going to have stasis, and whenever we have stasis in body, stasis leads to infection. Keep that in mind, okay? Whether it's in lungs, like for example, we'll be discussing a condition that is atrial fibrillation. So what happens in atrial fibrillation again is stasis. Your atria cannot contract. So once your atria isn't contracting, stasis leads to infection. So there can be increased chances of getting like endocarditis, that is inflammation of your endocardium. Is that clear? Okay, yes, Dr. Moaz.
Okay, can you guys hear me clearly now?
Yes.
Okay. So now we were on the topic that ostium primum. So an ostium secundum will be formed in the septum primum, right? So now the second thing will happen is that a second septum is going to form here. So right, this is the second septum which is going to form here, right? And it is going to cover the first septum. So this will be a flap-like septum that is going to cover the first septum, right? So it will form on the right side of the septum primum, and there would be a right to left shunt. So what does a right to left shunt mean? It means that the blood will grow from the right side of the body to the left side of the body. But so now, why is this thing important? Why do we want to move the blood from the right side of the body to the left side? Why is the heart in the embryological stage from the right to left thing? When we go into the fetal circulation, I will explain you this thing, right? Because this is very important. That why does this thing happen?
Can you explain
Right?
this concept once again? I got confused in the ostium primum and ostium secundum.
Can you repeat your question?
Please, can you explain this process once again? I got confused in ostium secundum and ostium primum.
Okay. So look, This was the heart. This is heart. This is the right atrium, and this is the left atrium, right? So these are the two atrium. Now we want to separate these things, right? So now there's a thing in here which is known as the endocardial cushion, right? But right now there is no separation. So the first thing that we do is the heart forms a septum from here and it goes downward. Since this is the first septum, this is known as the septum primum. I think everything is clear till now, right? And there is a gap here. This gap is known as the ostium primum. So the ostium means an opening, and primum means it's the opening. Right? So
Hello,
an ostium
Dr.
primum
Moaz,
will
your
form
voice.
here.
Hello?
Oh, wait a second. Wait a second. Wait a second.
Okay, so okay, let me just continue the discussion. Okay, Dr. Moaz, your question, Dr. Krishna, is that how do we get that septum? Okay, so as Dr. Moaz is fixing his mic,
Yes,
so
sir.
I'll just
Please.
continue with it. Okay, so the idea is really clear. First of all, we are going to have an atria, right atrium and left atrium. We have to divide them in between, right, in order to get proper right side and left side of atrium, right? Okay, hello.
Okay, sir.
Okay.
Yes, I'm
So
hearing you.
in order to divide that, first of all, we need a septum. Septum can divide it, right? So the first septum which is formed embryologically is known as septum primum. As the name indicates, septum primum is the primitive or the first septum which is formed, right? So basically the endocardial cushion cells are lying there, as Dr. Moaz just told you. They are neural crest cells which would just migrate into your heart. The septum primum is going to approach towards your endocardial cushion cells, but it would stop in between. It would not directly attach, get joined with your endocardial cushion. It would just stop in between, and in that way it's going to form an ostium or an opening. Opening means ostium, right? So as it's the first opening, so let me just name it as ostium primum. Is that clear? And it's very important to have this ostium in a fetus. Why? Because in the fetus the lungs are already collapsed and the fetus is already getting oxygenated blood from the mother, right? So there is no role of lungs within the fetus. So it's better to get all of the blood which is coming into your fetal heart directly into your left side, so that you can perfuse your baby, so you can just get blood into systemic circulation. That's why we need that ostium. Is that clear now?
Yes, sir. Very clear.
Okay,
Okay.
perfect.
Okay. So I will build on the thing. Okay. So I will build on the thing that just Dr. Ahmed said. So remember, guys, when a fetus is very small, when the fetus is a newborn, when the fetus is in the mother, especially when the fetus is between the age of 4 weeks to 20th weeks, the fetus will swallow a lot of liquids, right? And all of that liquid will go into the lungs of the fetus, right? So the lungs of the fetus and the arteries which are in the fetus are covered with fluids, right? Since all of the arteries and lungs in the fetus are covered with fluids, no blood can go there. So now we need a way to bypass the lungs. Why? Because blood from the right side of the heart goes to the lungs, and then it goes from the lungs to the left side of the heart. Now we need a connection to skip the lungs. In order to skip the lungs, we have this connection which is known as the ostium primum, right? But now we want to close this ostium primum and we form a new ostium which is known as the ostium secundum. So now why is that important? This is important for as is by left side of the heart becomes more strong. On average, a left side of the heart is 3 times stronger than the right side of the heart. So now since the left side of the heart is 3 times stronger than the right side of the heart, all of the blood can go from left side of the heart to the right side of the heart. So now we don't want that. So we want to close this thing. So how do we fix this problem that blood does not grow from the left side of the heart to the right side? In order to solve that problem, we want to close this area. So that we close this area first and then we form a new. So now we will close and we'll form a new ostium, which is known as the ostium secundum. So why is this thing is important? Why do we form this, and how this thing solve that problem. So now the septum secundum will come here, right? And whenever the blood wanna go here, it cannot go here through this, but the blood can go from here towards that side, right? So it forms a double valvular connection, right? So it acts as a one-way valve. The blood can go from the right side of the heart to the left side of the heart, but since it forms a one-way valve, the blood cannot go the opposite way. So it's just like a door that just opens on the outside, but it does not open on the inside. So this thing is known as this ostium secundum. So this will be ostium secundum, and this would be the septum secundum, right? That is the main logic, right? You do not want to go into so much details about this because this is not as high yield as that, right? But the thing that is important here is, let me tell you what's important here, and what is the thing that you want to focus on. Thing that you want to focus on is this. Since this is the ostium secundum, this ostium secundum mostly closes, right? This ostium secundum closes in every single person. If this ostium secundum does not close, it will cause a condition which is known as the patent foramen ovale, right? So how is this thing? How does this thing work? So if you look here, this is septum primum, right? This was a septum primum. This septum primum, when the baby born, or during the early childhood, the septum secundum and the septum primary fuse and they close and an atrial septum is formed. Right? The most important thing that they want to here is this. So now we have a condition which is known as the deep vein thrombosis. What is deep vein thrombosis? Deep venous thrombosis means that if a person is having a clot in his legs, so if a person has a clot in his legs, if this is the person and there is a clot that is present in his legs, that clot is gonna move towards the body. It's gonna move towards the heart. And why am I telling you this? Because this is one of the most asked question, and this is one of the most liked question by your NBMEs and USMLEs and your viewers and every user exam. This question will be always be present because this is a condition that occurs a lot, right? So the clot will move towards your heart, and after the heart, it will go into the right atrium, and after the right atrium, it will move into the right ventricle, and after right ventricle, it goes into the lungs. But the lungs, the circulation of lungs in adults is so small that the clot cannot move further from the lungs into the left atrium. This pathway will be blocked. When this pathway is blocked, the person will not get a clot anywhere else in the body, and he will get the clot only in the lungs from the legs. This condition will be known as pulmonary embolism, right? So this will cause pulmonary embolism in the child, in the person. Now, what the main problem that occurs in some people is that this foramen ovale, which closes in everyone, which was a septum second, which was the ostium secundum, it does not close. Now, normally this condition is asymptomatic. Normally this condition is asymptomatic and it does not cause any problem. But the problem occurs when a patient a DVT. So when a patient gets deep venous thrombosis, now the clot can bypass the lung and it can move from right atrium. So normally the clot will move from the right atrium into the right ventricle into the lungs. It will move from the right atrium into the left atrium, and through the left atrium it will go into the left ventricle and it can go to the brain, right? And then it can cause a brain stroke, right? So this occurs in two conditions. It can occur in patent foramen ovale, in which the foramen ovale is open, and the second thing that in which it can occur is the atrial septal defect, right? So now, why is this important? This is important because they can give you a question that a 45-year-old female comes to you and that patient was having a deep venous thrombosis. She was taking medications for that condition, but now all of a sudden, patient cannot move her legs, arms. Now, one would think that how is this condition causing a brain stroke? Because deep venous thrombosis does not lead to brain stroke. As I have already told you that the emboli cannot go to the, that is the main thing. It cannot move past the lungs. But now they would ask you, how is this thing possible? and they would give you the pathophysiology of the diseases. One of the pathophysiologies would mention this thing, that a failure, the failure of septum primum and septum secundum to fuse after the birth. One of the options would be this thing. So the atrial separation, the separation of the chambers is only important due to this main reason. Right? Now, second thing, which is a physiological thing that they could ask you, is they could ask you what is the type of shunt that is present in a newborn, and you would have to answer that. So the type of shunt that is present in a fetus that is still in her, that is still in the mother wombs, is a right to left circulation. So it is a right to left shunt. Now they would ask you what are the physiological changes that occur at the birth. So at the birth, the main thing that will happen is that when a baby is just born, we put a suction tube in the baby's mouth. So whenever a baby is born, we suction all of the secretions out of the baby's mouth. And when you suction all of that secretions out of the baby's mouth, the baby's lungs become clear. Now when the lungs become clear, the blood will move from the right atrium into the right ventricle into the lungs, and then into the left atrium. And the pressure of left atrium would increase a lot. When the pressure of the left atrium would increase, it will press this septum against this septum, right? So septum secundum will be pressed against the septum primum, and this septum will form. This septum will be closed, and there would be no more foramen avail. There would be no more gap in those things, and an atrial septum would form. So after birth, left atrial pressure rises, right atrial pressure becomes low. And how does this condition occur? I'm telling you again, this condition occurs because of the fact that the lungs now offer no more resistance to the blood, so the blood likes to go. Okay, so let me tell you one thing about cardiology that would help you a lot. In cardiology, there is a thing which is known as the blood always goes through the path of least resistance. So if a blood has two ways to go, it will always follow that path which offers the least resistance to the blood. Now you can think that if there is a foramen here and on the other side there is water in the lungs, can you just think which part of the body does the blood want to go? The blood will obviously go to the part of foramens, because in that area there is no blood, there is no resistance. But since after birth, now one more thing, we have studied a lot in our um, first and second year of medical school that pulmonary circulation is low pressure circulation. Pulmonary circulation is low pressure circulation. Why is this thing important? Because it offers a very low pressure. It offers very low pressure. So that is why all of the blood wants to go to the pulmonary circulation. So if you look at this thing, you would come to know that all of the blood from our body, from our legs, from our arms, from our brain wants to go into the heart and then wants to go into the lungs, because blood wants to follow the path of least resistance and lungs offer the least amount of resistance. This is a very much important tested concept that they would ask you again and again, right? So keep this thing in mind. Right. Now we'll move on to the ventricles, right? Now so now what will happen in the ventricles? Again, let's look at the ventricles. So if this is the ventricle, to the RV and this is the LV. Now in the ventricles there would be a muscular septum that will form, right? The septum in the case of atria wasn't that muscular, but here the septum will be a muscular septum. So muscular interventricular septum will form, and there would be an opening which is known as the interventricular foramen, right? So now there would be an entry which is known as the interventricular foramen, right? Now the second thing is that now now we all know that the right ventricle goes into the pulmonary arteries and the left ventricle goes into the aorta, right? So now an new septum will form which is known as the aortocopulmonary septum. What does this septum do? This septum will will go from here, from the pulmonary arteries, right? And it will go here, and it will go from the it will go from the aorta as well, and it will go into the left ventricle, right? So now two things will happen. The interventricular septum will close and this membrane will close as well, right? This will be the first thing that will happen. So remember, in case of ventricles, there will be two septums. The septums will be formed of two parts. One part would be the muscular part, and the other part would be the membranous part, right? And then they would ask you, what is the thing that the membranous part comes from? So the membranous part comes from the aorticopulmonary septum, and it results in the formation of two things, right? The number one thing is that it will result in the formation of pulmonary arteries and the left and the aorta, and secondly, it will form the membranous part of the ventricles, right? Now, how does the ventricle separate from the atria? So, in order to separate the ventricles from the atria, endocardial cushions will grow. And what are endocardial cushions? Endocardial cushions are things which come from the mesoderm. Right? We'll go into the detail about mesoderm later, but they come from the mesoderm and they separate the atria from the ventricles, right? And they will form two things. One, they will lead to the formation of atrial septation and membranous portion of the interventricular septum. So now, in order to summarize all of those things, the main things that you want to remember from this is that ventricle atria and the muscular part of and the membranous part of interventricular septum will come from a place which is known as the endocardial cushions, right? So they could give you a question that a researcher was doing a research on heart and he came across a thing which is known as an endocardial cushion, and he was wondering what parts of heart are formed by this. So what will be the part of the heart that will be formed by this? So there would be two things. First, the atrial septum, and secondly, the membranous portion of the interventricular septum, as well as the separation of atria, as well as the separation of atria from the ventricles. Now, why are these endocardial cushions important? I will tell you now. Let me check if there is some question first. Okay. Okay. So now the most important thing is that these endocardial cushions are important due to a disease which is known as this is a very famous disease, and the disease is Down syndrome. So in Down syndrome, there is a trisomy of chromosome 21. So there would be a trisomy of chromosome 21, and these people have a lot of problems. But the one thing that you want to remember is that USMLEs love to integrate different systems and different concepts. And Down syndrome is a prime example of that. In Down syndrome, there will be a lot of problems. There will be duodenal atresia, there would be intellectual defects, there would be high chances of acute lymphocytic leukemia, there would be high chances of acute myeloid leukemia, there would be high chances of Hirschsprung disease. A lot of different things can happen. But a very important thing that happens in Down syndrome is a defect in cardiovascular system. And now USMLEs want you to know that what is the defect in cardiovascular system that happens at the embryological level. So the thing that happens at the embryological level is that in Down syndrome there is a problem of the endocardial cushions. So endocardial cushions are the problem in Down syndrome. So whenever there is problem in endocardial cushion, what are the things that will be affected? The things that will be affected are atria from the ventricles, atrial septation, and membranous portion of the interventricular septum. Now, how does the USMLE can test you this in the exam? They can give you a question that a person with intellectual disability comes to you at the age of 11 years, right? And that patient had Hirschsprung disease as well. He had a history of acute lymphoid leukemia as well. And when you check the patient's chromosomes, you get a diagnosis that the patient has trisomy. Right? Now they could ask you, what kind of problems do you affect in his, what kind of problem do you think this person will have? And now, in order to confuse you, they will give you two options. Everyone knows that in case of Down syndrome, there will be a problems in the ventricular septum. So there will be ventricular septal defect. Now everyone will know this, right? So ventricular septal defect would be the problem. But now they could confuse you between two options. One would be membranous part of the ventricular septum, and the other would be muscular part of the interventricular septum. And you guys want to know that the membranous of the interventricular septum is formed by the endocardial cushion, and the main problem in Down syndrome is that endocardial cushion, right? So atrioventricular septal defect are very common in Down syndrome. They are also known as endocardial cushion defects, AV canal defects. Right? So these occur normally in Down syndrome. So if the problem is only in the ventricle atrial septum, then or then that condition is known as partial atrioventricular septal defects. But if it occurs in the atria as well as the ventricle, then this condition is known as the complete atrioventricular septal defects. Now you want to know the diseases, you want to know the associations that can lead to this condition. The number one is Down syndrome. The second, so now the other two are very much related. If a female is obese, she would have diabetes as well, right? So obesity and diabetes are very related. Now, if a mother has diabetes, she can also get atrioventricular septal defect. How? Because if a woman is having diabetes, then there won't be complete. So basically, endocardial cushion comes from the mesoderm, and in patients who are having diabetes, these endocardial cushions won't come easily. So there would be migration problems, and that would lead to atrioventricular septal defects. Right now, another thing is the ventricular septal defect. Right. So now this is the most common congenital anomaly of the heart. And remember one more thing, that the NBMs and USMLEs are. They could give you a question and they could say that that a patient, that a mother had a child with ventricular septal defect, and now she's planning to have another child. But the mother is very worried that the child may have ventricular septal defect. How to make sure? What are the chances of having ventricular septal defect in the next child? And then they could give you an answer of 0%, 20%, 25%, 50%, and 100%. Here the main thing is that the chances, or then they could give you an option of 2%, right? So remember, having ventricular septal defect in one child does not lead to an increased risk of ventricular septal defect in another child. These things are completely unrelated. Right? So if one child is having this condition, it won't happen in another child, right? So the chances would be 2%. So the chances would remain same, or it would be 2%. Right now, uh, let's move to the outflow tract formation. And okay. Okay. So now we'll move to the outflow tract formation. Now we'll move to outflow tract formation, right? So what is the outflow tract formation? Now another thing. How does the outflow tract forms? The derivatives here are very important. So neural crest cells comes. What are neural crest cells, right? So neural crest cells are the cells which come from the ectoderm, right? So we have an ectoderm in the heart. We have the ectoderm that is formed in the baby, and that ectoderm will lead to the formation of neural crest cells that migrate. And when these migrate, these will form truncal and bulbar ridges, which fuse to form the aorticopulmonary septum. And I have already told you how does the aorticopulmonary septum leads to the formation of aorta and pulmonary trunk, right? So that is the way that neural crest will lead to the formation of this, right? So now, if there is any problem in the failure of neural crest cells to migrate, we would have three conditions. Right. One is transposition of the great arteries, then the other one is tetralogy of Fallot, and the third one is persistent truncal stenosis. After completing these things, we will move on to this, but let's first move on to, let's just complete these things, right? Now, regarding the last is the valve development. Regarding valve development, you just have to remember one thing, that the aortic and pulmonary valves comes from endocardial cushions. And again, if a patient is having Down syndrome, these will be affected, right? And the mitral and tricuspid valve will come from the fused endocardial cushion of the AV canal, right? And the other ones, the ones of the aortic and pulmonary area are from the endocardial cushions of outflow tract, and the mitral and tricuspid ones are from the endocardial cushions of the AV canal, right? So the Downs one will be affected more. Now there is a condition which is known as the Epstein anomaly. What happens in the Epstein anomaly? We have to go over that. So if this is the aorta, if this is the right atrium, and this is the right ventricle, there is a valve here, right? This is known as the tricuspid valve. This is known as the tricuspid valve. But if a mother is taking lithium, Lithium is used for the treatment of bipolar disorder. Again, the USMLE is asking this way that a mother was taking lithium for the treatment of her bipolar disorder, or a mother is having a bipolar disorder and she was on some kind of medications, and now the baby is born with a defect. So what would be that defect? So what would happen is that this would be the right atrium. In case of Epstein anomaly, if this was the right atrium, the valve would move downwards, right? So the valve would move here. So all of the right ventricle would become atria as well. So if the valve was here, the valve would move from here to here. It will move from here to here. And this will be right ventricle, and this will become a lot larger. So this is known as the atrialization of the ventricles. So atrialization of the ventricles, which means the ventricles become just like atria, is a condition which is known as the Epstein anomaly, right? Yes. So why? Okay, just a minute, sir. Can you repeat? Okay. Can you explain 2% again? Yes. So 2% is because there are the chances of ventricular septal defect are 2% in a normal. So the person would have the same amount of ventricular septal defect as a normal population. The other thing is that what other conditions follow this principle? The other second most important condition is cleft palate, right? So it's palate, right? So if a patient is having cleft palate, which is a very common developmental defect, it won't increase the chances of having cleft palate in the other baby as well, in the other person as well, right? So cleft palate and cleft palate and ventricular septal defect and atrial septal defect are the things that occur in this, right? Now, one more important thing first, before we move forward. Atrial septal defect and ventricular septal defect. USMLE atrial and ventricular septal defects because these present as a murmurs, right? So we will cover the murmurs of atrial septal defect and ventricular septal defect. So how does the murmur of atrial septal defect sounds like? They would give you that there would be fixed wide splitting of the S2. I could go into the detail of how does this happen, but once we'll doing the murmurs, we will go into the detail and splitting, that what is fixed wide splitting. But for now, you want to remember that they would give you that there is a fixed wide splitting of S2, and that thing would occur in atrial septal defect, right? And in ventricular septal defect, there would be holosystolic murmur. So there would be a holosystolic murmur at left lower sternal border. So there would be a murmur, holosystolic murmur at the left lower sternal border. And again, if the patient is having atrial septal defect, then that patient could have a paradoxical emboli. That patient could have an emboli from the legs which go into the brain, right? And the patient could also be having patent foramen avail, and the condition would be same. And now you would think that Dr. Moaz just told us that patent foramen avail leads to that, and atrial septal defect leads to that as well. So how would we differentiate between what would be causing the problem with families, because they would give you both options as the right answer. But the thing is that you would look at the sign. If it says that the auscultation is caused, on auscultation you hear fixed wide splitting of S2, then it means that the problem was due to atrial septal defect. But if the problem is due to, it's not due to, if there is no fixed wide splitting of S2, then it's not due to atrial septal defect, right? Right. So okay. So listen. Now this is an important table that you want to remember, right? So this in even this a lot of things are not important. But oh, right. So this table is not that important, and it's not asked a lot, right? The important thing that you want to do here is we want to focus on the truncus arteriosus, right? So truncus arteriosus gives rise to ascending aorta and the pulmonary trunk, right? In the same way, endocardial cushions. These are important because these are the problems in the Brown syndrome, right? In the endocardial questions will give rise to atrial septum, membranous interventricular septal, AV, and semilunar valves, right? So these are the things that you want to remember. These are the important ones. Remember, we have to focus on the high yield things, not everything. So keep your focus on these ones, and you can skip the other ones, right? No, Dr. Ahmed was telling us about a condition which is known as the atrial fibrillation, right? So it is a condition which is known as atrial fibrillation. So what is atrial fibrillation? Remember, guys, our creator or God has designed the body in such a way that whenever we have whenever everything should move in the body. If there is stasis of any single thing in a body for just some seconds, a lot of serious conditions would happen. What is atrial fibrillation? Atrial fibrillation means that the heart starts beating very fastly for some time, especially the atrium. And when that happens, blood does not move in the heart. The heart beats so fast and it does not contract completely that blood gets there is a stasis of blood in the atria. And remember, if you have bleeding or any, or if you just make the blood stay in one place for just 1 to 2 seconds, the blood would clot, right? So atrial fibrillation leads to clotting, and it is very common in atrial fibrillation to have clotting, right? So atrial fibrillation cross clotting. But the things that USMLE is want to know you is that anatomically, what part of heart causes the clot to form? And that part of heart is the trabeculated portion of left atrium. So the trabeculated portion of trabeculated part of left atrium is the part that leads to the formation of that clot. And another thing is, where does the atrial fibrillation arises from? So the atrial fibrillation arises from the pulmonary veins. Let's check if someone has a question, then we'll move forward. Okay, so this was clear till here. Now, again, let's go in. Now, these are some fetal postnatal derivatives, and so there is nothing of such important concept here. The main thing is that you want to remember these. So there are some things that are present. We'll go into the foramen ovale. First of all, let's read to foramen ovale. So foramen ovale will become fossa ovalis, right? And ductus arteriosus. We'll go into the let's first go into the fetal circulation first. And okay, let's first do the anatomy, and after that we'll move on to the fetal circulation, right? Because fetal circulation is important, right? So what's the anatomy of the heart? So anatomy of the heart is very simple, right?
Sorry for interruption. Dr. Amita, can you just please fix your mic? Dr. Amita, can you please? Okay, thank you. Okay, so Dr. Sabir is asking a question, Dr. Moaz.
Yep, let me see. Let me see. Okay, so let me tell you one thing. So it does not. So remember, guys. I'll explain this in the anatomy of the heart, right? I'll make it easy, and I will explain this in the anatomy of the heart, and I will combine those two things, right? So, if you see, if this is the left atrium, there are some points from where the pulmonary veins will drain into the heart. The pulmonary veins drain into the heart here, right? So the points where the pulmonary veins drain into the heart are known as the ostia of the pulmonary veins, or the origin of the pulmonary veins. So these are the points where the atrial fibrillation will arise. Now, why is this thing important? This thing is important because if you guys want to become an electrophysiologist, which is first you do 3 years of internal medicine training, and then you do 3 years of cardiology fellowship, and after that you do 1 year of electrocardiophysiology. Then you work on these things, right? What do you do in these conditions? So this is very interesting, and I love this thing. So for that, you want to see the anatomy of the heart. So if we see, the heart starts from the right atrium, right? The heart starts from the right atrium, it goes into the right ventricle, then it goes to the pulmonary trunk. Pulmonary trunk goes into the pulmonary arteries. Pulmonary arteries will then forms pulmonary veins, and pulmonary veins will go left, and then it would go into the left ventricle. That is the adult heart circulation. That is the circulation of the heart. So now what do we do is that we insert a catheter, right? So we will insert a catheter in one of our arteries. So it could be radial artery or it could be any other artery, right? Or we could insert in a vein, and then we go into the right atrium, and from the right atrium we move into the right ventricle, and then we go into the pulmonary arteries and veins, and finally at the point of pulmonary veins we ablate. So we apply a lot of heat at the pulmonary veins. And when we apply a lot of heat at the pulmonary veins, the point where from where the pulmonary from where the AFib was coming from just goes away, right? So when that point goes away, the atrial fibrillation goes away. So now how do they wanna ask you this question? So they would say that an electrophysiologist is treating a patient's condition, and that patient was having irregular heartbeat for the last 2 years. And due to that irregular heartbeat, that patient had 3 episodes of clotting as well, right? And now the patient is on medications, but medications is not solving any of those problems. So the cardiologist decides to solve that problem, and he wants to ablate that place. Where will the cardiologist be ablating at? And then they could give you pulmonary veins, then they could give you pulmonary artery, then they could give you right atrium, right ventricle, left atrium, right? So that is the thing, right? So you know that it would be pulmonary veins. Now the other thing is that trabeculated portion. So if we the left atrium has two parts, right?
So, Dr. Moaz, sorry for interruption. Could you repeat this portion one more time?
Yep.
Yes,
Okay, I'll
doctor,
repeat it.
because you're completely getting interrupted. Like we can't hear anything.
Yeah.
Okay.
Dr. Moaz, can you just fix your mic? So if you can just give me a chance so that I can just continue a little bit. You till that time you can just fix the mic. Is that okay
Okay,
with
I
you?
think yep, that's okay with me.
Okay, so please can you just fix your mic?
I think it's
Okay.
fine now. Can you hear me clearly?
Yes.
Okay, yes, you can continue, Dr. Moaz.
Okay.
We can
So
hear
guys,
you now.
I was telling you there is a condition which is known as atrial fibrillation. So what happens in atrial fibrillation is that, so if this is our left atrium of the heart, right? Let me pull up a good diagram here. Would be a good diagram. Yes. So if this left atrium, right? This is the left atrium of the heart. There was a good diagram here. Let's go over that one first. Right. Yes. So yes, this is a very good diagram. So this is the left atrium. This is the left atrium of the heart, and these are the pulmonary veins. So this is the pulmonary vein number 1, and it is emptying here, and this is the pulmonary vein number 2, and it's emptying here, right? So these are known as the ostia of the pulmonary veins. So this is the point where the atrial fibrillation always arises from, right? So we want to fix this part. So how do we fix this part? In order to fix this part, we go from here, we go from the inferior vena cava, we reach the right atrium, and from the right atrium, we move into the right ventricle. From the right ventricle, we move into the pulmonary trunk. From the pulmonary trunk, we move into the pulmonary artery. From the pulmonary artery, we go all around. We go to the pulmonary veins, and here we have the catheter. And then we apply a lot of heat. When you apply a lot of heat at this place gets cauterized, and that atrial fibrillation part is gone away, right? That was the number 1 thing. The number 2 thing is that when the left atrium parts, one part is smooth, the other part is rough. The rough part is known as the trabeculated part, and this is very, very important, right? So there is a trabeculated part of the left atrium. This rough part is known as the trabeculated part of the left atrium, and at this trabeculated part, blood likes to stagnate whenever the body cannot pump blood. So if the body cannot pump blood due to any reasons, so like there is asystole, or the most common one is atrial fibrillation, the blood will collect at this trabeculated part. And when blood collects at this trabeculated part, it will clot, and a lot of clots will form, and it will go into the brain, and that will lead to stroke, right? So they could ask you that a 55-year-old male comes to you and it was having irregular heartbeats for the last 2 months, and now all of a sudden he did not get any checkup for that, he did not follow up with that doctor, and now all of a sudden the patient cannot speak anymore, and he is having problem in moving his right arm, right? And then they could ask you, what is the part of the heart that led to this condition? And you would think that, oh my God, the problem was in the brain and the problem is in the arms and the patient cannot speak. But why are the USMLEs expecting me to answer the heart? So here you will first have to make that connection, that a major cause of stroke in the patients who are having irregular heartbeats is atrial fibrillation. And the number second thing is that atrial fibrillation will cause clots, and the clots will be present in the trabeculated part of the heart. And now the third thing that you want to remember is that how does this condition get solved? So in order to solve the condition, we have to ablate the pulmonary veins, and ultimately that will solve that condition. So I think that's it. Now, okay. Yes, the left atrial appendage and the trabeculated part are exactly the right thing. Right. So now let's move on to the anatomy, because the anatomy is very important, right? So, guys, the heart is a 3D structure. One part of the heart is present in front of your body, and the one part is present towards the back, right? So remember one more important thing. If this is the body, the trachea is always present at the front of the body. Trachea, and then comes the esophagus. So trachea is in front and the esophagus is behind, right? And in front of this is the heart. This is the first thing that you want to know. Now the second thing that you want to know is that the heart is lying in a transverse plane, right? So if they ask you what is the most posterior part of the heart, the most posterior part of the heart, or the part that is facing the trachea and esophagus, is the left atrium, right? So the left atrium is the part that is towards the most posterior of the heart, and right ventricle is the part that is towards the front. This is very paradoxical, but this is how it works, right? So the most front part of your heart is the right ventricle, and the most posterior part is the left atrium. So for example, if someone stabs you in your chest, uh, if someone stabs you in your chest and you get bleeding or anything, and they ask you what part of the heart did the stabbing occur in, so the stabbing would have occurred in the right atrium if it was from the front. But if the stabbing was from the behind, then the most likely chance was that the left atrium was damaged, right? So the stabbing was in the left atrium. That is the first thing. Now the second thing is that I told you, if this is the heart, there is the trachea and there is the esophagus, and left atrium is towards the end. So if left atrium becomes big, this left atrium will compress the trachea and it will compress the esophagus. So when the trachea is compressed, there would be so first let's move to esophagus. So when the esophagus is compressed, there would be dysphagia, right? So the patient would have difficulty in swallowing, right? The second is that a trachea or bronchi would be compressed, there would be some kind of dyspnea and hemoptysis, right? So the patient would have bleeding, bleeding from coughing, right? So that is known as hemoptysis. And the third thing is that just behind this structure is a structure which is known as the left recurrent laryngeal nerve. And when this left recurrent laryngeal nerve which be compressed, there would be hoarseness of the voice. Now, why is this thing important? Where does the left atrium becomes enlarged? The most common cause of left atrium becoming enlarged is a condition which is known as the mitral stenosis. Now, how does this mitral stenosis comes into play? Now, this is the point where the USMLEs want you to confuse. This is the point that the USMLEs want you to know, right? So, what is the most common cause of mitral stenosis, and which is the most common places where this thing occurs, right? So, they would give you a question. So, since you are preparing for a USMLE exam, remember that most of the population of the US, a lot of population of the US comes from outside world, from different countries, from immigrant countries. They want to know, they want you to be sure about different immigrant populations, right? So they could give you, let me give you a question. So they could give you a question that 35-year-old female comes to you, and that female is having hoarseness of her voice, and the female is having dysphagia, and you would be very much surprised that how is this woman having dysphagia, hoarseness, and hemoptysis at the age of 35 years old. And then at the same time they would tell you that the woman was from a underdeveloped country such as Pakistan, India, Bangladesh, Sri Lanka, Nepal. They love these countries when they want to mention an underdeveloped country, right? Or they could give you the question was from Mexico, right? They would ask, give you these things, and then they would say you, now the patient is having this condition. So what is the likely diagnosis? So how would you know what is the diagnosis? But here the main thing is that the people from underdeveloped country get a lot of sore throat in their early childhood. When they get a lot of sore throat in their early childhood, after sore throat due to Streptococcus pyogenes, there is always a chance of a disease, rheumatic fever, if you do not get antibiotics. Now, this is another concept that is very important. So, there is a condition, there is a bacteria which is known as a Strep pyogenes. Strep pyogenes causes two infections. One is cellulitis, another is sore throat. The two important ones, right? And then both of these can lead to root conditions. One is the rheumatic fever, and the other one is post-streptococcal glomerulonephritis. Now, they could ask you, first thing they could ask you is that a patient was having sore throat or cellulitis due to Streptococcus pyogenes, and we give the patient antibiotic. What would be prevented and what would not be prevented? So, rheumatic fever could be prevented if you gave that patient antibiotic. And what is rheumatic fever? Rheumatic fevers mean that the patient would have fever, the patient would have joint problems, the patient would have arthritis, and the arthritis would be migratory. What does migratory arthritis mean? Migratory arthritis means that they would give you a female, a patient, that a 13-year-old female comes to you, and that patient has sore throat, and the patient did not get any antibiotics for it. And now the patient is having pain in the knee, and after 10 days the pain moved to the arms, and now the patient has pain has moved to the toes. This is all a migratory arthritis. And then there would be nodules, there would be erythema marginatum, and the patient is having irregular movement of the hands, and then they would say patient is having murmurs in the heart. And when the patient gets, this is another important thing, when the patient gets rheumatic fever, the most common murmur that the patient would get at that time is mitral regurgitation. And it will solve. It will solve on its own. The patient's murmur would solve. And the patient would think that I am normal now. But after 10 to 15 to 20 years, that mitral regurgitation murmur will come back as a murmur of mitral stenosis. So now the patient would be having mitral stenosis, and his or her mitral valve would become very stenosed or fibrotic. Now, since the mitral valve is very stenosed, the blood will not move from left atrium to the left ventricle, and the left atrium would become very enlarged, and then the blood will compress on esophagus, and it would compress on the left recurrent laryngeal nerve as well. It would cause hoarseness, dysphagia. So that is how a patient from an underdeveloped country ends up in these things. Won't give you the hint of Orton syndrome. You have to diagnose it yourself, right? So that is the thing, that you have to diagnose it yourself. And then they could ask you, what is the part of the heart that is leading to this problem? Now again, you would think, how on the earth is this patient having this condition, right? Or they could ask you, what is the next best step that you would do in this patient? So the next best step is that you would do an echocardiogram in this patient. So you would thinking that if a patient is having the patient is having what, maybe we should do this endoscopy or some kind of bronchoscopy to lead up to the diagnosis. But you have to look at the question carefully, right? You have to look at the stem, you have to look at the history. And don't worry, in these 120 days marathon, we'll go through all of these cases and all of those conditions and every single disease, and it's very easy for you, right? So now next is pericardium, right?
Excuse
So the
me, Dr.
pericardium has
Mas,
three
could
layers.
you repeat?
What do you want me to repeat?
The relation of the rheumatic heart failure with the Ortner syndrome.
Okay. Okay, so when the patient is having rheumatic heart fever, at that time the patient would be having mitral regurgitation, right? Which is very common. And after that, then mitral regurgitation would go away. But since the patient had an infection, and remember, whenever a body has infection and that infection lasts for long, the body will try to fight that infection. And when you try to fight some infection, there would be damage there. And whenever there is damage to some walls, the walls cannot repair that damage, so the walls get fibrotic. And when that walls get fibrotic, that condition is known as mitral stenosis. So there would so that condition, so the patient would get mitral stenosis, right? So now the patient would have mitral stenosis, and mitral stenosis would cause the lungs to become larger. And when the lungs would get the left atrium to become enlarged, and that left enlarged atrium would press on the esophagus and the left recurrent nerve, and that would cause the problems, right? Okay. Okay. Now, we'll
Okay,
move on
thank
to
you.
pericardium. So pericardium has yes. So now the pericardium has three layers. One is fibrous three layers. So one is fibrous, there is parietal, and the third one is epicardium, right? So the pericardial space which is affected is mostly between the pericardium and the epicardium, right? And pericardium is innervated by the phrenic nerve, right? So now there is a condition in which there is infection or inflammation of the pericardium, which is known as the pericarditis, right? We would go into the pericarditis and the pathology here is important. The patient having pericarditis, the patient often has pain on the back and on the arms, right? And why is that? Why does that happen? It happens because pericardium is innervated by the phrenic nerve, and phrenic nerves also has a similar origin to the nerves of the arms and shoulders and neck, and that causes the problems, right? So pericardium is not that important. The coronary blood supply is very important. So you guys have to listen to it carefully, right? Let me check if there's some question. Okay, okay. Now, so the blood supply of the heart comes from the two cells. Okay. So the heart supply of the blood comes from two areas, right? So that there is right part of the heart and there is left part of the heart, right? So the most important one is the left part. Why is the left part important? Because I already told you that left part provides three times three times as much force as compared to the right part. So the left part provides three times force as compared to the right one. Okay, right? So now, what is the innervation of the left side? Now let's move at this diagram, right? So this is the front part, right? And the main artery that supplies, so the front part is the left anterior descending artery, right? So there is an artery which this is the left anterior descending artery, and it supplies the interior part of the heart, which is the main part of the heart. So interior two-thirds of the interventricular septum and all of the interior surface of the heart is supplied by the left anterior descending. This artery is most commonly occluded. And when this artery is included or cause problems in myocardial infarction, almost all of the front of the heart is damaged. And when that is damaged, the patient has very bad ejection fraction and the heart's function become very worse. And that leads to devastating outcomes, right? And then, so interventricular septal has two parts. There is the anterior two-thirds and there is the posterior one-third. The posterior one-third is supplied by the posterior descending artery, and the posterior two-thirds of the ventricular walls as well is supplied by the posterior descending artery. Right. So remember this thing. Posterior descending artery is when this is damaged. This is not as big of a problem as the front one. But there is one thing that is important. That is, posterior descending arteries supply the SA and AV nodes of the heart. Right. So whenever posterior descending artery is affected, and so remember that SA and AV nodes cause one important. They cause the heart to beat, the heartbeat of the heart, right? So your heart beats due to the SC and AV nodes. And if SC and AV nodes are damaged due to posterior descending artery problems, then there would heart problem. There will be problem heartbeat and there will be bradycardia or heart blocks. Right? Now, what is supplied? How is the right ventricle supplied? The right ventricle is supplied by the right marginal artery. The most important
So
is the LAD.
please repeat this part.
Yeah.
So,
Okay.
could you please
So
repeat this
remember,
part again?
so if we go, okay. So if you look at the, भाई तुम लोग 5 मिनट रुक जाओ. Okay, so if you look at the heart, first of all, we have to look at the what is the main part of the heart. First we want to remember that the main part of the heart is the left ventricle. Then there are two parts of the left ventricle: the anterior part and the posterior part. Which artery supplies the anterior part? Left anterior descending artery supplies the anterior part, and the anterior part of the heart is the most important part, right? So if LAD is there, if LAD is damaged, left part of the heart, anterior part of the heart gets affected, and there is a lot of problems, right? Now, if now let's move on to the posterior part of the heart. The posterior part of the heart is supplied by the posterior descending artery, right? And then there is the interventricular septum, which has two parts: the anterior part and the posterior. The anterior would be supplied by the left anterior descending, and the posterior would be supplied by the posterior descending artery. One important thing is that there is dominance of the heart, right? So what is dominance of the heart? So there is one important thing which is known as the SA and AV node, right? Why are these nodes important? These nodes are important because these nodes will cause the heart to beat, right? These nodes will cause the heart to beat, and these will cause heart. So if these nodes beat harder, the heart will beat fast and there would be tachycardia. If these nodes are problematic and they don't function properly, then the heart would beat slow and there would be bradycardia. So the blood supply of these nodes become very important, right? Now the important thing here is that we want to see, so the blood supply of these arteries come from the posterior descending arteries. Right? Now we want to see that which artery supplies the posterior descending artery. So the posterior descending artery normally comes from the right coronary artery, right? So some people are right dominant, some people are left dominant. In left dominant, the artery comes from the LCX, right? So why is this important? Let me tell you. There are two types of heart attack. There is a right-sided heart attack and there is a left-sided heart attack. In the right-sided heart attack, the right side of the heart and the right coronary artery is affected. Whereas in the left side of the heart, left-sided heart attack, left coronary artery is affected. So now, I told you that posterior descending artery supplies the SA node and AV node, right? So which kind of heart attack will most commonly lead to bradycardia? Anyone?
Right.
Yes, exactly. Why? Because the right part of the heart, right-sided, when there is problem in the right coronary artery will supply the posterior descending artery, and posterior descending artery will supply the AV node. In 80% or 70% of the patients, this will happen. So when there is a problem with the right side of the heart, the patient would have bradycardia. Whereas in the left dominant circulation, PDA will come from the left circumflex artery, right? And in some patients, PDA comes from both, right? Now another important thing is that when does heart gets its blood? So the heart gets blood from the coronary arteries, which are the right and left coronary, and then these are branches, right? So the heart gets its blood when the person is resting, when the heart is resting in the diastole, right? So in early diastole, when the heart is resting, then the heart gets its blood. Now another important thing is that if a person is exercising, so if they love to give this. If a person is exercising, and if the person is exercising very fast and the heart is beating very fast, will the diastole be reduced or will the systole be reduced? Right. The answer is that the diastole of the heart will be reduced, and as a result of that, in exercise the heart gets less blood because the heart beats fast, and when the heart beats fast, the main thing that happens is that diastole gets reduced, and the heart will get supplied blood supply. Systole, heart,
Can't hear.
heart. Okay, blood. Heart gets its blood during.
Hello,
The heart gets its. Hello,
hello.
can you
Dr.
hear me?
Moss, your voice is breaking too much.
Okay. I think it. Let's try again. Is it better now? Hello.
Yes, it's
Sir,
right.
it's
Yes.
not my job, but I think you need to catch your breath.
Okay.
We can wait for
So I
we
was
all can wait for 2 minutes.
okay. So I was saying that during the the main last important thing is that, and that will be finished here, is that heart gets in which part of the circulation of the heart that does the heart gets the blood. The one part is the systole, during which heart contracts, and the other part is the diastole, during which heart relaxes, right? So why does you will and NBM is asked this question a lot, that why does the heart gets its blood supply during diastole and not the systole? And the answer is that because during systole the heart pumps so hard that the blood vessels get constricted in the heart. So the heart won't get the blood in the systole, and it will get the blood in diastole. Now, ask is, increase the heartbeat of a person from 60 to 100 or 150, which part of the blood cycle would be affected? So the cycle that would be affected is the diastole, right? Because diastole would be affected, and as a result, supply of the heart would be affected, right? So, guys, this was still here till anatomy, and so tomorrow we'll continue. And the fetal circulation, we want to do it with um, the pathologies of the heart, the developmental genetic pathologies of the heart, congenital heart anomalies. So we will continue it with that, right? So this was from me here today, right? So
Okay.
that's it for today.
Please do not leave the session. Anyone? Thank you so much, Dr. Moss, for having such an amazing session and such an enlightening session. Right? So, okay. Thank you so much. Okay. So this was
Thank
all
you.
about session with Dr. Moaz, and like you guys know that it was a great session. He discussed a lot of things, and keep that in mind that each and everything which Dr. Moaz say is really important, not even for your step 1, but your step 2 and step 3 as well. Thank you so much. Right. So after Dr. Moaz session, we'll be continuing, like we have decided in this marathon, that after the Dr. Moaz class, we'll be having discussion over the topics, right? So yes, Dr. Moss have did his job. So I'll be continuing the discussion about today's topic. You guys, I'll be asking you some questions regarding today's topic, and all of you guys must participate, right? It's a kind of review, right? Like I'll be having half an hour of review with you guys. Is that clear? Okay. So, okay, perfect. So everyone should be mentally prepared. I can ask anyone, okay? Just keep that in mind. So as Dr. Moaz discussed from the first, who is going to tell me Kartagener syndrome? What is Kartagener syndrome? And as Dr. Moaz just told us, what pathologies are related with Kartagener syndrome. So I'll just name you, and you guys have to turn on your mic and just, have a discussion over that, okay? Okay. So yes, Dr. Nimra, can you just please tell us what is Kartagener syndrome?
Cardiovascular syndrome is a syndrome in which there is defect in the dyning protein and it leads to
Okay, perfect.
dextrocardia and
Dextrocardia.
it
Okay,
has various manifestations. It affects the cilia and the flagella and all of the structures of lungs, nose, etc. Sperms are affected by it and their motility is not possible and it leads to infection.
okay, perfect. That's perfect. So Kartagener syndrome, let me mention again. Okay, if you guys have any questions in today's topic, you can just ask me, okay? Anything. So I'll be here for a question and answer session, right? So yes, as Dr. Nima explained, that what is Kartagener syndrome is basically a defect of dynein protein, okay? So let me just share my screen. Okay, can you guys just see my screen?
No, sir.
No.
Okay, wait a second. Can you just see it now?
Yeah.
Yeah.
Sir.
So first of all,
Yes.
if you guys have any questions regarding today's topic, you can just ask me. You can just let me know. I'll just try to explain it. As Dr. Moaz explained each and everything in great detail, but still, if you guys have any question, you guys can ask me.
Sir, the last part was not clear to me.
Okay,
Yeah,
The
that's
so
left
very
there
easy.
was
circulation
like
and the
the
right
blood
circulation.
supply part.
Okay, please one by one, please raise your
And
hands and then
diastolic,
ask me questions.
systolic.
Okay, that's quite easy. Okay, that's quite easy. Don't be worried. We are here at your back, as we already mentioned. So we are going to discuss that in detail. The idea which Dr. Moaz gave us was quite clear, right? Like for example, if this is your heart, right? Can you guys just see my screen?
Yes.
Okay, perfect. You know that the left side of your heart is like quite a bulky structure. Why is it a bulky structure? Because your left heart of your side of your heart would pump into your systemic circulation. And systemic circulation basically is a high resistance system. Like even the left chamber is responsible of getting blood into each and every organ of you. So it means that it must be strong. It must be having a lot of muscle. It must be having a lot of power. Is that clear? Hello?
Yes. Yes.
Just please, okay. And as we know that the coronary vessels which Dr. Moaz discussed are present at the epicardial surface. What do we mean by epicardial surface? On the superior or the superficial surface of your heart, right? So whenever your heart is constricting, okay, why do your heart contracts or constrict? In order to pump blood into your aorta and systemic circulation, your heart must contract. But the contraction is so high that these vessels become constricted. As these vessels are the part of this big muscle, so as this muscle is exerting force in order to push blood into aorta, that force also constricts your blood vessels as well, coronary blood vessels, right? So that's why during systole, what is systole? Systole is contraction. During contraction, as these vessels are constricted, so your heart during systole cannot get its own blood because heart itself is supplied by these arteries. Is that clear? While during diastole, when your heart is relaxing, right? So now your coronary vessels are open. They can perfuse your heart. Is that clear? Hello?
Yes. Clear.
Okay. Any other question?
It's clear.
Yes, please. Dr. Aksa, can you just please turn on your mic? Can you just ask any question? Yes. Please turn on your mic. It's a discussion session. You guys can ask me anything. Okay,
Could you
don't
please
make it
explain about the dominant part?
perfect. That's easy, right? Okay. Let's suppose this is your aorta, right? Okay. So your coronary vessels comes directly from your aorta, right? Like this is going to be your right coronary artery, and this is going to be your left coronary artery, right? Right coronary artery and your left coronary artery. The right coronary artery mainly is going to supply the right side of your heart, right? And what lies on the right side of your heart? Like for example, if this is your heart, it's going to supply which structures on the right side? Yes, you guys are going to be telling me that, please.
Right atrium, right ventricle.
Right atrium or right? Okay, so your right atrium, and let's suppose your right ventricle. Okay, and the left coronary artery is going to give another branch, which is basically known as LAD, left anterior descending artery, right? And another branch which is known as left circumflex branch, which is going to supply the left periphery of your left side heart. Is that clear? This is the simple anatomy which I am discussing. Is that clear?
Yes,
Yes.
clear.
Okay,
Yes.
perfect. But the inferior surface of your heart, like your heart have inferior surface as well. Inferior surface is basically supplied by an artery which is known as PDA, posterior descending artery, supplies the inferior surface of your heart, right? Is that clear till now?
Yes.
Okay, so PDA is going to supply the inferior surface. So in the question stem, they can just tell you we have an individual, he's having myocardial infarction and he's having ST segment elevation in the inferior portion of your heart, right? Inferior portion of your heart. So what do you think, which artery is disrupted? That is PDA, right? PDA.
Yes.
But the other question which is arise in your mind, in 80% of individual, PDA arises from your right coronary artery. Is that clear? The PDA arises in the right coronary in 80% individual, like most of the individuals, right? So in the question stem, whenever they haven't given you any, like if they haven't clearly mentioned that whether individual is right dominant or left dominant, you should directly think of he's a right dominant individual because majority is the authority, right? Hello?
Yes.
But in the remaining 20% of individual, the PDA arises from your left coronary artery, but specifically which branch of left coronary artery?
Left circumflex.
Left circumflex. It is one of your UWorld MCQ. They're going to ask you this, okay? Specifically left circumflex, the 20%, in 20% individual, it would come from left circumflex artery, which is going to supply the inferior surface. While in the remaining, like some of the individual, it comes from both your right and left coronary artery, and those individuals are going to be called as codominant individuals, right? Hello?
Yes.
Yes.
Perfect. Is that clear now?
Yes, it's
Yes.
clear. Thank you.
Okay, let me just mention another thing. We know that where do SA node lie? It's very important. One of your World MCQ. Can you just tell me the exact location of SA node? Yes, who is going to be telling me that?
Is it right inferior to the superior vena cava?
Okay, okay, in the right atrium near inferior vena cava or superior vena cava?
Like inferior to the superior vena cava?
I
Okay,
think
anyone else?
it's superior vena cava.
Superior vena cava, right? So there is it's going to lie, okay? And SA node itself need an arterial blood supply. So right coronary artery basically supplies your SA node. Keep that in mind. So whenever we have an infarction of right coronary artery, there would also be bradycardia, right? Because SA node is important for sending the first signal to your heart and controlling your electrical activity. Is that clear? But for the AV node, you must keep that in mind. Very important, very high yield, that the AV node is basically supplied by AV nodal artery. AV nodal artery. And AV nodal artery comes from PDA. And we also know that PDA can itself come from either right, or it can itself come from either left, or it can be codominant, right? Is that clear? So AV node is really important. If in the question stem they mentioned that we have an individual, he's a right dominant individual, okay, and now he's having, let's suppose, an AV block, right, due to, let's suppose, infarction. Because if you are infarcting the AV nodal artery and an individual is right dominant, it's obvious that AV nodal artery would be arising from PDA, and PDA itself would arise from right heart because he is right dominant. Is that clear?
Clear.
Hello?
Yes.
But we can have an individual who is left dominant. In that case, the AV nodal artery would be arising again from PDA, but PDA itself would be arising from your left circumflex, that is left dominant individual. Is that clear?
Yes.
Any other questions? Yes, Dr. Aksa.
Yeah, so I have a question. I have the 2024 first aid version, and it says that the right circumflex artery supplies the AV node and the SA node.
Okay.
But in Dr. Moaz's book, it said that the PDA supplies the AV node, SA node, and the posterior one, third, like, etc. So which is the right one?
Okay, as I have mentioned, things are very clear. In your first set, they are just telling you that, okay, what are they telling you? What's the statement in your first set?
The statement in mine is that the right coronary artery supplies the AV node and SA node.
Okay, okay. Exactly. They are talking about the common individual. The most common 80% individual are right-sided individuals, right? So they are talking about the common population.
Dr. Ahmed.
Is that clear now?
Yes.
Yes, like mostly individuals are 80% are right dominant. It's obvious that AV node and SA node both are going to be supplied by right-sided circulation. But if they were just talking about the left-sided individual, in that case, AV nodal artery would be arising from your left circumflex. So both of them are correct. Is that clear?
Yes.
Okay.
So
Anyone
doctor, basically AV node will be supplied by PDA. We just have to see the orientation and then we will
That's the
understand
point.
it.
That's the point. That's the point.
Okay, thanks.
Okay. Anyone else?
Yes, Dr. Ahmed, I think it's a virgin issue because in 2025 they said SA node and AV nodes between brackets as determined by dominance. So I think maybe they make it in the 2025 version of this.
You should there are books, and books can have a lot of mistakes, right? Whatever we are just teaching here, that's like you can say those who have old version, they can correct if there is some problem, but at least you guys know the concept, right? Okay. Anyone else? Any questions?
Yeah, I have a question.
Sure.
With regards to the left anterior, or I mean the right and left coronary artery, giving off their branches. So we are saying that the left anterior descending artery supplies, does it supply just the anterior surface of the left ventricle, or it supplies the anterior surface of the entire heart?
Okay, so LAD basically is going to be supplying certain specific structures. That is 1/3 of your interventricular septum. What else? You guys are going to be telling me that. Yes. What else do LAD supply? One of the papillary muscle as well. That is anterior lateral papillary muscle. What else?
Anterior surface of the left ventricle.
Okay, anterior surface of the left ventricle. And anterior surface, like mostly it's going to be formed by your right ventricle, but you don't have to be confusing that, okay? Because within the structure in the first set is different, and in a real human, the orientation is entirely different, right? The structure which is of the heart, which is mentioned within the first set, that's quite different from your, from a real human. So you cannot just compare that anterior structure with a real human, because the real human anterior structure is basically made by your right ventricle. Is that clear? So there is an MCQ. We have an individual, he have a stay-bound injury between third and fourth intercostal space, medial to his sternum. What do you guys think? Which structure of your heart is going to be damaged? Yes.
Right ventricle.
The right ventricle. Perfect. If the same injury is directed laterally, then what do you guys think? Which structure is going to be damaged?
Left lung.
Left lung. Left lung.
Left lung maybe, yes. If depends upon the lines, like parasternal lines or
yeah. Perfect. Like if it's medial to the sternum, it's going to be your heart. If it's lateral to the sternum, it's going to be your left lung. That's it. Anything else? Any questions? Yes, Dr. Mujtaba.
Okay.
Yes, Dr. Joanna, you can just ask your question.
Yeah, I was wondering, you said third to fourth intercostal space.
Yes.
Where is the injury coming from? Because I thought it's the left ventricle. I heard right ventricle. I was a bit confused.
Okay, if we have a stay-bound injury, if someone is stabbing a dagger in between third and fourth intercostal space, right? And if it's medial to the sternum, then your heart is going to be damaged. And which structure? The anterior surface. Anterior surface is formed by?
The left ventricle.
Right. No, it's right. Keep that in mind. Okay, if the injury is at mid-clavicular line, fifth intercostal space, then it's going to be your left ventricle.
Okay, thank you.
That is the apex of your heart is going to be ruptured. Anyone else? Yes, Dr. Mujtaba.
Okay, doctor, I have a question about VSD that it happens at 2% population. That's confusing to me.
Okay, you are asking about VSD that occurs in 2% of population, right?
Yes.
Okay. So the idea is really simple. As Dr. Moaz was just telling us that, for example, if we have a mother, let's suppose, and and we have let's suppose a baby with Down syndrome, right? So the chances of getting, VSD with a baby of having Down syndrome is only 2%, right? That's simple. That's a global value which you have to keep in mind. But if the same mother get another baby of Down syndrome, so it do not if you have a one baby with Down syndrome, it do not increases the chances of VSD in other baby. It have no relation. That's the main point.
Can you repeat that again? Can you repeat what you said again? You said the mother with the Down syndrome, percentage of the baby.
No, if a baby is having a Down syndrome, right? So there is 2% of chances. And mother is diabetic. That's also one of the case, right? So there is 2% chances of the baby to get VSD, right? Hello?
Yes. Okay. Yes.
Okay. And but just keep that in mind. 2% of chances of getting VSD. Simple.
Okay.
Thank you.
Anything else? Yes, please ask questions because it's an opportunity for you guys. You guys are open. You can just open your mic. Any questions regarding cardiovascular? It's your time. I only have 5 minutes left. You guys can just ask any questions regarding atrial fibrillation.
Hi, Doc.
Yes, please.
So, Dr. Moaz mentioned that mothers with diabetes and obesity has some issues related to migration. So I did not understand that part. Could you please explain it, with respect after Down syndrome?
Okay, no problem. Okay, so basically, what are endocardial cushions?
They derive from mesodermal tissues, which
Okay.
helps in the formation of the muscular part of the septum, as well as in the
Okay.
atrial septation.
Just forget the book's
Yeah.
wording. Let's just get into a little bit more detail. We have 3 layers whenever the baby is forming, right? Your ectoderm, your mesoderm, and your endoderm. Mesoderm is going to form a structure which is known as notochord. Notochord is going to send some signals to the ectoderm. Ectoderm is going to be transformed into neural plate, right? This neural plate is going to invaginate. It would just form neural tube, right? And once we have formation of this neural tube, at the same time, we are going to have formation of certain cells which are known as neural crest cells, right? Hello?
Yes.
Yes.
Yeah.
These neural crest cells are going to migrate to different parts of your bodies, giving rise to different structure. For example, if it migrates into your kidney, it would just give you an adrenal medulla, right? If it migrates, let's suppose, to your skin, it would just give you melanocytes. If it migrates to your heart, it's going to give you endocardial cushion cells, right?
Right.
Okay. And what these endocardial cushion cells are going to do, like as Dr. Moaz discussed, we have atria and we have ventricles, and here we have endocardial cushions, which are migrated mesodermal cells, or which are your neural crest cells. Is that clear?
Yes.
Okay. And as Dr. Moaz mentioned, we have like septum primum, which is coming here, right? It's going to like get attached to your endocardial cushion, and then we are going to have a foramen and secundum, right? Remember? Okay, so these endocardial cushion cells are helping this portion of the atrial septum to form, right? So can I say that endocardial cushion cells helps in interatrial septum formation? Yes or no?
Yes.
Perfect. Similarly, you have interventricular septum coming like that. So interventricular septum basically have a muscular portion and a membranous portion. So can I say that the membranous portion of your interventricular septum also is like the endocardial cushion cells are responsible for making the membranous portion of your interventricular septum? Can I say that?
Yes.
Yes.
Perfect. Perfect. Right? So whenever we have, okay, these endocardial cushion cells are also going to play other roles as well, not only this formation. It's also going to help in formation of your tricuspid valve, in formation of your bicuspid valve, in formation of your aorticopulmonary septum. What is aorticopulmonary septum? Like your aorta and your pulmonary system, that is pulmonary artery, used to be a single vessel. But these endocardial cushion cells help them to make a septum in between them, and then it was separated into your individual aorta and, okay, your individual pulmonary artery and aorta, right? Hello?
Yes.
So can I say that endocardial cushion cells help me to make my interatrial septum? It helps me to make my tricuspid valve. It helped me to make my bicuspid valve. It helped me to make the membranous portion of your ventricular septum. It helps me to make the septum between your aorta and pulmonary, that big vessel, which is known as aorticopulmonary septum. Can I say that?
Yes.
Yes.
After formation of this aorticopulmonary septum, what happened that there was a process of spiraling. So once it becomes spiral, then your aorta is going to be arising from your left ventricle, and pulmonary artery is going to arise from your right ventricle, right? But if we have, okay, in diabetic mother, as Dr. Moaz mentioned, there is failure of these cells to migrate into your heart. If we have in diabetic mother, and obviously diabetes is associated with obesity, like whenever we have an obese female, so there would be insulin resistance, which we'll be talking in our endocrinology section, right? Are you guys following me?
Yes, doctor.
So diabetic mother, in diabetic mother, there is failure of transferring or failure of getting your endocardial of your neural crest cells into your heart. That is failure of endocardial cushion to migrate into your heart, right? If we do not have endocardial cushion cells in the heart, so this septum won't be formed. Can I say that?
Yes.
Yeah.
If this septum do not form, what's the pathology called? That is persistent truncus arteriosus. Right? Hello?
Right,
There
right.
would be problems with your septum. There would be problems with your interventricular septum. Is that clear now?
So, doctor, since you mentioned that these cells migrate to kidney, heart, skin, and forms adrenal medulla, so all these can also be affected because of the diabetes condition.
Okay. You should just keep that in mind. Like these are the concepts behind. Like it's not necessary that it do not migrate to other parts of your body as well, but it is necessary that, like, certain impact of certain pathologies are greater at a specific organ, right? So the impact here on heart is more as compared to the other system. Is that clear?
Yes, doctor. Thank you so much.
Okay.
So they would
Anyone
have,
else?
they can have atrioventricular septal defect
Yes, they can
and
have.
persistent truncosarteriosis.
Yes, they can have.
Thank you.
Anyone else? You only have little time remaining, please.
Hi, doctor. I have a question.
Sure.
Okay, so Dr. Moss was explaining that which chamber of the heart is most likely to be affected if the injury is from the front side and from the back side. So can you please re-explain that?
Okay, that's very simple, right? For example, if this is your heart, right? This is your anterior surface of your heart. This is posterior surface of your heart, right? Anterior surface of your heart is mainly made by which structure? Right ventricle.
Right ventricle.
Posterior is mainly made by your
Left atrium.
left atrium. And just posterior to this structure, you have esophagus.
Esophagus.
And just posterior to esophagus, we have
the trachea.
Trachea.
Descending aorta. Keep that in mind. Your UL MCQ, not trachea. Trachea trachea lies anterior to esophagus or posterior to? When I try to grab someone collar, and I'm just trying to grab someone collar, so do I just catch his esophagus or trachea? That's trachea. Trachea is anterior, right?
Yeah.
Okay. So keep that in mind. Whenever we have an injury which is directed to anterior side, it's going to give us rupture of your right ventricle. Although the posterior side injuries are uncommon, or I would say impossible, right? Can you step someone from posterior side? It's very hard. You can, but it's very hard. You need a long dagger, and you need a proper anatomical structure knowledge in order to get a step. But an important point which you guys must remember that, for example, if you have a condition that is mitral stenosis, what happens? Your left atrium is going to become enlarged, right?
Yeah.
And as it becomes enlarged, it's going to compress your esophagus, which is going to give you dysphagia. That's very important. Or another thing, you have a UL MCQ, they'll be just telling you we have inserted a camera, transesophageal echocardiography. We have inserted camera till the mid esophagus, and we are pointing towards the heart. So we are going to take pictures of which structure of your heart. That's going to be
left atrium.
Okay, now we have just rotated this camera by 180 degree, and we are just viewing this portion. What do you guys think? We are going
Descending aorta.
Descending aorta.
That's clear. So we have discussed almost each and every MCQ of your word here as well, right? Anything else? Is that clear? Okay. So this was our session for today. So let's have a little bit feedback session. Can you guys just tell me, did you guys enjoy today's session? I'm like to start
One more question. Dr. Moss did mention he will discuss fetal circulation today. Is it like missed out or for the next session?
Okay. You don't have to be worried. We are going to discuss that in some other session, right? Don't be worried. We are here. Don't be worried. You are going to have like me and Dr. Moaz as well, so you don't have to be worried. Like the more questions you ask, the more your brain is going to be open towards your USMLE preparation, right? And the more you are going to be like, an active learner. Okay. Any questions?
Yes, thank you for the session. My question is, now there is some other topics like remnants of the fetal mean the derivatives that fetal and neonatal also not discussed, and I have noticed that there is some MCQs in UR regarding heart embryology, that which part in adults is from which part from the fetus, like
Okay.
Sinus venosus. We have to discuss, or we have to ourselves study this one?
As you know, Dr. Mahin is going to discuss that in UWorld, and these are some small things. Like we'll just try to cover the concepts, the high yield things. Like your USMLE is not only about your cardiovascular, it's not only about endo, it's about everything, right? So we are going to discuss each and everything in detail. The main things which I'll just mention here, you'll only see MCQs of certain 2 or 3 things, and Dr. Morris already mentioned that the truncus arteriosus is very important. What else? The cardinal veins are also important. Cardinal veins basically give rise to your superior and inferior vena cava. That's important. Just note it down. You won't see any MCQ in NBME and UWorld other than that.
Okay, thank you.
Okay.
Thank you.
So, okay, so let's have a little bit feedback session, because we want this marathon students to be like, best prepared for their exam. So do you guys have any feedback? Did you guys enjoy the session? Anything, any suggestions?
So,
I love the session. It was really good. The explanation, because I've learned the first page, the embryology of cardiology before. I found it difficult to understand the questions and everything, but I think with the explanation given today, I have a good understanding, and I don't think I'll forget it again.
Okay, what Dr. Just request that Dr. Moss fix his mic next time. Definitely he'll just fix his mic. He's okay. Can we get discount code? Okay, we are just talking to the UWorld team, and if if they give us discount code, then we are going to announce in the group. Okay. Okay. And the UWorld sessions are also going to be like in such detail as we did today, right? I'll be there in the UWorld session right after Dr. Mahin's session. So if you guys have any questions, I'll be there at your back. Okay. So, anything else?
So, can it would be very kind of you to ask Dr. Mohan.
Your voice is breaking.
Hello.
Yes.
So it would be very kind of you to ask Dr. Mohan to take a little pause while explaining things, because some of us are also noting down our notes for revision after the class. If I found it the explanations were very nice, thorough, but it couldn't. I was not able to note down the main points.
Okay. Krishna, let me just mention that taking notes is like, I would say, isn't a good way of studying, right? In my opinion. So it would be better if you just listen things, if you just consume the concept, consume the content, because you guys, I know it's your first day, you guys would be like really thinking of that what's going to happen. It's a lot of information, but we are going to revise these things again and again. Like atrial fibrillation isn't going to leave you even till end of your neuro, right? So we are going to do things again and again. Like tomorrow, you guys can just revise things. Then tomorrow we are going to have a UWorld session. In the UWorld session, we are going to revise same things again. Then again in the bootcamp session, we are going to revise it. Then for your assessment, you are going to revise it. For now, just try to grab the concepts. Thank you. Right? And as in this marathon, we are going to cover each and everything. We won't miss anything, right? Not even a single MCQ of your word. So like we are just trying our best. And like we know, we already have conducted like 2 to 3 batches. So the way which we are moving on, so you guys should adopt to us, okay? It's for your benefit.
Sir, I have a little question. If we're starting a module and we have to read the book, so should we just start reading from FA directly, or should we follow a content guide from somewhere, like the USMLE content guide, or from where should we
You
see
don't
the
have
topic?
to follow anything. These lectures which we give are more than enough. Just follow these lectures, go read your first aid, and I'll be sharing the schedule within 2 hours. So you have 2 hours for your revision, just revise. I'll be sharing the UWorld question IDs and each and every topic which we discussed today. Go just do it from your first aid. Just copy the question ID to your UWorld, practice the UWorld. You should be more focused on questions, on practicing UWorld, right? Not noting down things, reading first aid or reading other books. That's a passive way of learning. You do not recommend to do that. You should be more, okay, first aid itself is a revision book. It isn't a content book. Whatever we are teaching you here, that's there are like pinpoint focus things. right? You should be focusing on these sessions. These kind of information you won't get in any resource. If it's BNB, if it's boot camp, you won't get this kind of information and live interaction anywhere. So use this platform for your success, and that's all. Okay, so I'll be sharing the question IDs. Yes, we have recorded the session.
you.
We'll just share the recordings, and that was all for today. Thank you so much, and have a nice day.
Thank you, Doc.
Thank you.